recorded. Good day, everyone. The National Center for Interprofessional Practice and Education is pleased to present this online educational program. This is Andy Pollan, Communications Manager with the National Center. On behalf of the National Center staff, I am pleased to welcome you to our 6th Journal Club. For those of you new to the series, the Journal Club is an opportunity to discuss the immediate impact of recent research in the field of interprofessional practice and education. I'm joined by my colleague and Journal Club moderator, Dr. Nawal Lutfia, and our featured guest, Dr. Emily Leasure. The basis of the discussion is Dr. Leasure and her co-author's 2013 article in Academic Medicine, which reviewed the teamwork competencies needed for high-functioning teams and offered suggestions on how those competencies might be useful for interprofessional team training and the achievement of patient-centered medical homes, or PCMH, standards. The National Center would like to thank Academic Medicine for making the full text of this article freely available. If you are following on Twitter or are interested in doing so, you can join a real-time conversation about this webinar using the hashtag PCMHTeams or by following the National Center at the handle NexusIPE. Again, I would like to welcome our featured guest, Dr. Emily Leasure. Dr. Leasure is an assistant professor in the Department of Internal Medicine at the University of Nebraska Medical Center in Omaha. She received her medical degree from Emory University in Atlanta and completed her internal medicine residency at the University of Cincinnati, where she also served as chief medical resident and associate program director of the internal medicine residency. During her time as associate program director, she also led a hospital quality improvement project which involved restructuring the general medicine teams to practice interdisciplinary bedside rounds on geographic wards. Dr. Leasure took her faculty position at the University of Nebraska Medical Center in 2011. She serves as a clinician educator in both the inpatient and outpatient settings for medical students and residents and is also an associate program director for the internal medicine residency. She serves as chair of both the Internal Medicine Clinical Competency Committee and Program Evaluation Committee. An area of interest remains educating learners and colleagues on interdisciplinary bedside rounding techniques. Dr. Leasure is a preceptor at the Midtown Clinic, a resident-run patient-centered medical home that trains resident physicians alongside licensed medical and family therapists, nursing students, social work students, and pharmacy students. Moderating our discussion today is National Center Senior Research Scientist, Dr. Nawal Lutfia. Dr. Lutfia is a chronic disease epidemiologist who was elected a fellow in the American College of Epidemiology as recognition for significant and sustained contributions to the discipline of epidemiology. Dr. Lutfia holds a faculty position in the College of Pharmacy, Department of Pharmacy Practice and Pharmaceutical Science at the University of Minnesota. Prior to joining the National Center, she held appointments with the Winnipeg Regional Health Authority as a senior epidemiologist and the University of Illinois Chicago College of Medicine at Rockford, where she was the director of research for the Department of Family and Community Medicine. She also served as a senior research scientist at the Essentia Institute for Rural Health, where she was director of research for the Education Division. Dr. Lutfia has graduate degrees from the University of Iowa and Iowa City and University of Massachusetts Amherst. She completed her undergraduate degree at the University of Manitoba in Winnipeg, Canada, and further, Dr. Lutfia is fellowship trained in primary care research. She was the recipient of an Alpha Omega Alpha Clinical Teaching Award and has been published in a wide variety of journals, including the Journal of General Medicine, BMC Health Services Research, Healthcare, and the Journal of Interprofessional Care. Presently, she is an associate editor for the journal BMC Health Services Research. Thank you both for joining us. Today's discussion will last about 50 minutes and includes a question and answer session at the end of the program. You can queue up a question at any time via Twitter using the hashtag PCMHTeams or by typing it into the Q&A box and then clicking the send button. Links to additional websites and documents, including the slide deck, can be found in the chat box on the right side of your screen. Now I will hand the webinar over to Dr. Lutfia to begin the discussion.
Hi, everybody. I want to thank Dr. Leasure for agreeing to be a part of this webinar today. We're quite excited to have you here, and I have to say that I found your paper, There is No I in Teamwork, in Patient-Centered Medical Homes, Defining Teamwork Competencies for Academic Practice, quite interesting and informative. Before we begin, would you like to briefly give a shout out to your co-authors and tell us a little bit about each of them?
Yes, sure. Thank you. Thanks for the opportunity to be here, but also to introduce my team of authors. I am one of the more junior members of the authorship team, so I've gotten the pleasure of learning so much from them and their expertise. It's hard to do them all justice, but I'll give it a shot. So
All right.
my co-authors are all just a wonderful group of innovative physicians and nurses who represent really varied practices, types, and sites throughout the U.S. Several of us authors have really gotten to know each other through our work as either associate program directors or program directors of internal medicine residencies. We all are involved with the APTIM organization and the Educational Innovations Project. At the time of the SGIM Summit that gave rise to this paper, I was actually still at the University of Cincinnati working alongside Dr. Eric Warm, one of the authors, who's the program director of the residency there, and he's also my personal mentor. And then some of the other authors, Dr. Ron Jones is on the program leadership at Summa Health System in Northeast Ohio, and Dr. Lori Mead is at Bay State Medical Center, part of Tufts University. Dr. Chris Thomas is an associate program director at Mayo Clinic in Rochester, Minnesota, and really this group of physicians I've gotten to work with and collaborate with in various areas of the Educational Innovations Project in APTIM. So that's how we got to know each other and got to work together. Dr. Judy Bowen is currently directing interprofessional education, faculty development, and other things at the Oregon Health and Science University, and she really was the inspirational leader of the SGIM Summit that led to the work of this paper. Marla Sanger is a nurse and an administrator working at the time of the paper for Peace Health in Vancouver, Washington, and she really provided a lot of insight and input to our team regarding patient partnership and care system improvement, which was really vital to our team. And then finally, Dr. Ginny Tilden, she truly functioned as an expert of our work group in interprofessional education. She's a leader in the development and study of interprofessional education innovations. She's currently professor and interim senior associate dean for research in the School of Nursing at Oregon Health and Science University. And I believe that both Ginny and Lori actually are participating in the webinar today, so I'm going to give them a special shout out for being a part today.
Thank you. My first question about this paper is what gave rise to it? What brought you folk together to address this issue and produce this paper?
Sure. So as I mentioned, there was this SGIM Summit, or the Society for General Internal Medicine Education Summit back in 2011, and this was organized by Dr. Julie Bowen with input from lots of leaders from the American Board of Internal Medicine, the American College of Physicians, APTIM, Association of Subspecialty Professors, and others. And really, she put this together with big, lofty goals and brought a lot of us from areas around the country together to work in a two-day summit, but then we all did really several months of pre-work leading up to it and then several months of work following the summit. And the goal of the summit was really to answer the question, what must we do differently to prepare internal medicine residents for their futures, both practicing in and leading patient-centered medical homes? Historically, residents at academic primary care practice training sites, they train in more chaotic, sometimes dysfunctional clinics that are less well supported, yet charged with caring for the sickest, most complex, underserved patients and communities. So we're not really setting up these residents for success. We expect them to choose primary care and then enter the workforce ready to collaborate as part of a high-functioning care team. And we recognize this as a problem and said, how do we prepare them better to function and lead in these patient-centered medical homes? So as part of the summit, there were 7 work groups formed, and my group of co-authors and I formed the teamwork group, hence the focus of this paper, but the other 6 groups focused on different areas like continuity of care, assessment, faculty development, and others. So our subgroup, charged with thinking about teamwork, explored different features of high-functioning teams in order to brainstorm what elements does a resident need to be trained in to be a high-functioning member of a PCMH care team. So we asked all the summit participants from all the work groups to give us some examples from their own practices or training sites, some specific examples of where they've seen teamwork lead to better patient outcomes and better resident training outcomes, and where they've maybe seen an absence of teamwork lead to poor outcomes. And then we all drew from our own experiences as well and put together a lot of the limitations and frustrations that we all shared to put together that case vignette, which all the discussion in the paper stemmed from. So we hoped that with the work of this paper that we could help provide a framework for teaching, reinforcing, and assessing teamwork skills and competencies for IM residents in training.
Thank you. That was very informative to hear how this came together. I thought when I read the paper that the case or vignette that you and your co-authors presented to build examples from was quite well done, and I liked how you integrated and referred to it throughout your article. You know, that's a real difficult sort of chore to do, and I think you did it very well. Since your paper brings together patient-centered medical homes and team competencies, could you define patient-centered medical homes for us to make sure that we're all on the same page?
Yes. A patient-centered medical home is really a model of care delivery. It organizes care around the patient with big, lofty goals of improving patients' access to care, the quality of care they receive, safety of care delivered, and efficiency for primary care delivery really in America. So it's not a physical place, it's more a model of care. The model requires that medical homes not only provide comprehensive care that's patient-centered and coordinated, but also demonstrates a commitment to system-level and population-based quality improvement. So for a clinic to be able to be certified as a patient-centered medical home, it must meet certain standards, and these are seen in List 1 of the paper. But the PCMHs that do meet these standards can get recognized as such then by the National Committee for Quality Assurance, or now the Joint Commissions as well.
Thank you. I very much like the way you organized your paper, as I said earlier, and especially as you introduced the Big 5 competencies for high-functioning teams that comes from Eduardo Salas's work. Could you briefly tell us what the 5 competencies are and define them for us before we get into greater detail?
Sure. Sorry, go on.
Oh, and I was just going to say, as an addendum to that, could you explain where these Big 5 core competencies came from?
Yes, definitely. So the first competency is probably the most intuitive, and that's team leadership. Probably even since we were kids, everyone understands that a good team needs a strong leader, but that's more the traditional kind of hierarchical sense of leadership. And though that's necessary, what we really wanted to push and what Eduardo Salas and his competencies postulates is that for some leadership, there's such a thing as a fluid shared leadership, and we really see that being the type of leadership in a patient-centered medical home where the role of leader shifts based on the task, it shifts based on the team, on the problem, on the solution. So really, any member of the team should be put in a position to be able to be the leader to solve a certain issue. In our paper, we use the example that a scheduler should be the right team leader to be put into place to recognize issues such as long wait times for patients to get appointments. And so if that's the right person to be the leader to identify the problem, then they see it through with different interventions to try to improve wait times, give that feedback to the team. And so it's really a fluid leadership that we see as being necessary in a patient-centered medical home, in addition to the overall patient-centered medical home kind of hierarchical traditional leader. So the leadership competency is really the one that links all the others. It absolutely has to be there, and it's essential to meet any of the patient-centered medical home standards, really. Mutual performance monitoring, I really think of this as the team members all being put into a position to keep everyone else in check. So here, hierarchy really doesn't matter. Everybody should understand each other's roles and goals, and the team goal should be a common shared goal. So we should feel empowered to give feedback to any team member, even if they may seem above our level. We provide feedback in a fashion that they also can provide feedback back to us, and this should be very much cultivated and reinforced. So it's feedback both formally and just frequent informal debriefings to provide monitoring of each other's performance. Backup behavior is the ability to shift who does what in order to solve problems and fix when one team member is overwhelmed or if a patient's care outcome for that day is not being met based on certain problems happening in the clinic. Then all team members need to be aware so that those problems can be identified and responsibilities can be shifted. So the essence of this is really that team members need to shift what they think of as their to-dos each day in clinic to define success as interdependence rather than independence. And this is something really challenging, I find, to train residents on, to get them to realize that their to-dos in clinic each day shouldn't be to see all their patients, make the right diagnoses, and treat with the right meds. It's really how do we as a care team achieve the patient's goals. So it's a different way of looking at the same list of check boxes, if you will. The adaptability competency is the ability of the team to change their processes or strategies based on outcome data or feedback from team members, feedback from patients. So it's the ability of the team to recognize that there's been a change and then actually change processes to react to that. And lastly is the team or collective orientation, and this is really the tendency for individuals and the team to prioritize team goals over their own individual goals and to show respect for each other team members, respect for their input, respect for their contributions, and really to enjoy being a part of a team. So to some degree this can be instilled and cultivated and increased, but to another degree sometimes people are just more team-oriented than others. So this one is, I think, one of the most important but also most challenging of the 5 competencies. And where these 5 competencies come from, you referred to Eduardo Salas, and definitely what our team of authors did is when we were getting ready for our pre-work before the summit is we took a step back and did a literature search, all of us individually, to try to see what teamwork constructs were out there, what were available, what kind of fit with our experiences in a patient-centered medical home training environment. And that's when we kind of stumbled upon and discovered the big 5 teamwork competencies by Eduardo Salas and his colleagues. And we felt that they best fit what our experiences in working in these settings. So not only does he describe these big 5, but there's a couple other really important supporting elements of shared mental model, mutual trust, closed-loop communication. And what we found after pouring through some of his research and thinking about our experiences is it's just so fascinating that in the work of the military, aviation, surgical teams, or primary care teams, though we all do such different work, these same teamwork competencies, skills, and behaviors, they're very common despite there being very different fields of work.
Thank you. That was very informative. When I read your paper, I thought that Table 1 in the article really quite brilliantly lays out each teamwork competency with examples of problems and how a high-functioning team would, could, should act, along with the elements of the patient-centered medical home dependent upon the team competency. And I wondered if you would be willing, or could you walk us through this table in order to illustrate the big 5 competencies for us. And so to facilitate this, I've taken the liberty of putting slides together, breaking out your table by the competencies for each slide, as you'll see when I go to the next slide. And here I have teamwork competency 1, leadership. And so maybe for people who may not have read the paper in depth, if you could just briefly mention the vignette and
yes,
then,
of course.
Yeah, talk through this. I should have made a slide of the vignette, and stupid me, I didn't. So
no problem. Yeah, I'll definitely summarize it.
Thanks.
So in the paper, we summarize a kind of classic patient vignette that when you first read it, you think it couldn't possibly actually happen that way, but unfortunately all of us authors have experienced similar things. So basically, a patient has a frustrating experience where he is going along fine with his hypertension, getting his meds refilled from afar, when a resident who had been his prior primary care doctor leaves the residency, and he's assigned a new intern, and the intern asks him to come in for an evaluation so that his blood pressure could be evaluated. But there are several kind of hiccups to that appointment, long delays, and basically the patient leaves that a very inefficient medical appointment with a lack of understanding of the care plan, which leads to the wrong care plan being enacted. He gets an unnecessary blood draw, which would have to be repeated, so increased expenses. He has no close follow-up, and there's no contingency plan in place for his negative health outcome of a persistently elevated blood pressure. So the case highlights a lot of frustrations on a lot of levels. The patient ended frustrated, the resident felt helpless and frustrated, the nurse was frustrated. So there's a lot of frustrations, and it definitely emphasizes the difficulty in providing continuity of care in a resident practice when residents are inconsistent providers in terms of their presence in these clinics. They may just have one half day of clinic a week. They may go a full month without clinic if it's more of a block schedule or if they're on an ICU rotation. So it makes it very difficult for a patient to have a consistent provider presence. So in looking at the table, just to orient you, so the team competency is in the column on the left. The second one is the problem identified where this, like in this instance, leadership is clearly lacking. The team is uncoordinated. There's not evidence of any evaluation or feedback to the team with these negative outcomes. The tasks were poorly distributed, and a lot of responsibility fell on an overwhelmed intern. And there was clearly a lack of inspiration and shared vision. The third column is kind of where the money lies in this table, and that's where we all provide recommendations of how you could improve leadership in this fictional case, but then applied to a real patient-centered medical home, of how care could have improved in this vignette if leadership would have been better accounted for. So basically in this example, engagement of the team toward patient care ownership. And this ownership is another one of the things that I feel like I spend a lot of time trying to teach and ingrain in residents, because truly owning the patient's outcome is something that really the team needs to adapt. So when the patient had this bad outcome, who's the one responsible for that? It shouldn't be one person. It's really the team ownership of that, but there must be ownership. Secondly, the formation and coordination of accountable care teams. And this idea is to try to provide some of the continuity of care that can be lacking in the resident practices. We suggest in the paper that this is done by having several residents be on a care team led by a nurse, and that way every time the patient comes, they see a familiar face in the nurse leader of that care team. And then if it happens to be a week or a month where their primary resident is not in clinic, there's still a member of that care team present to titrate blood pressure medicines or see the patient if there's a new problem, so that it provides some more of that continuity. We suggest execution of weekly practice meetings to bring the team together and foster that team collective orientation, provide feedback to troubleshoot solutions to problems, clarify team members' roles, etc., to recognize and prioritize population health interventions. I think if this is not done formally as part of a weekly practice meeting, it often would not happen, and this is something we're trying to train our residents to be cognizant of. And lastly, the facilitation of just continuous quality improvement, performance review, and feedback, and that should be on a pretty rapid cycle timeline for the team. So as you can see, there are 6 PCMH standards, and for this competency, every single one of them relies on strong leadership to be achieved.
Thank you. The second competency is mutual performance monitoring, and I've put this second table up for discussion. Do you want to walk us through this one?
Sure. So how mutual performance monitoring was clearly lacking in this case, the examples in that second column, there really were team member-oriented processes rather than patient-center-oriented processes. And so there was a lack of understanding of each other's roles and how other team members could have assisted. There was no feedback to the intern about no care plan in place for if the patient returned with a high blood pressure, et cetera. There's a culture that really underemphasizes the team member's potential. So in our suggestions for how to improve this competency in this case would really be a creation of shared patient-centered practice goals. It's changing from an that checkbox thing that I referred to earlier. It's changing each team member from the mentality of what do I need to accomplish in clinic today to what does our patient need from us as a team in clinic today, and that really shifts as you look at your fellow team members to give feedback and to make sure that everybody is working toward achieving that patient-centered goal. Developing that expectation of feedback and communication within team members, and this is done, it has to be done frequently and have it be reinforced that this is just expected, and if you are constantly debriefing, it's much less, it feels much less like you're in trouble if somebody tells you should have done something different, if it's just a culture of constant feedback. This communication skill of how to interact with members of the other disciplines needs to be taught and observed and assessed as part of the residents' training. This is where Marla gave us a lot of good thoughts on how we need to incorporate patient advisors or a patient advisory committee to provide the patient's input as a member of the team of how we could have improved care in this case or how on a system level our clinic could improve care. So really the PCMH standard that this competency is necessary for is really that measurement and improvement of performance, or PCMH 6.
Thank you. Backup behavior, competency 3.
For this competency, again, like I mentioned earlier, the intern was kind of left hanging a little bit. So there was a lack of a system in place to help out an overloaded resident. There was unsuccessful processes in place to get this patient scheduled in a more timely fashion rather than waiting until they were absolutely out of meds and with uncontrolled health outcomes. There was a lack of provider availability for follow-up. There were a failure among team members to be aware of the problem in terms of needing to fix it, and then a failure to recognize a patient's lack of understanding and health literacy. There's really no element of assessing for that in this case. So the ways that we suggest improving backup behavior are to start having a pre-visit care team huddle at the beginning of each clinic half day where the team members kind of review what patients are coming in that day, talk about what care needs they might have, and plan ahead if it looks like there's going to be several patients that might require more time. Have almost a backup behavior already in line. If this happens, then who will do what, and so on. And then educating and cross-training for all these processes. So we can't just expect backup behavior to happen. We need to help train each team member to understand what would be expected, and definitely walking through cases like this with a team can help team members identify ways that they could have maybe provided better backup in this scenario. For example, in this case, if they had a pre-visit care huddle of and understood backup behavior, a pharmacist or a nursing student or an educator of some sort could have stepped in and saw the patient when there was a long wait time waiting on the doctor, and several of these pieces and problems probably could have been prevented. Another piece is to develop practice solutions for problems such as expected absences, and this, again, is expected. It's a residency practice. So there are going to be times where providers are not available, so this is something we should be prepared for with a backup plan. And lastly, a very important one is to try to manipulate the space and the scheduling that you have as a clinic to increase the amount of team member interactions. The time that people spend in a room together will actually increase the chance that you'll identify when someone is falling behind, and it'll improve the chances that you can step in and help. So it's that shared space and schedule that actually really helps a team run smoothly in this competency. So the PCMH standards dependent on this are 1, 3, and 4, as you can see in the fourth column.
Thank you. Adaptability is the fourth teamwork competency that you discuss.
And this one it kind of goes hand in hand with the one prior, but it's really the team to identify those problems and shift in real time, but also shift longitudinally to affect processes. So in this case, the failures were that there was a failure to recognize the practice pattern that was causing problems. There was a poor allocation of resources, the resident was unsupported, and team members were unprepared for the day. So ways to improve this would be to educate all team members on a shared model of care, to emphasize team-oriented goals rather than individual goals, to simulate cases like this or kind of work through case vignettes like the one we just did with team members so that they can start to think about how we might, as a clinic, need to adapt our processes, to utilize weekly meetings to identify and correct practice problems. Things that would have been identified from this case are the actual discharge from the clinic process, to implement better patient education on the plan, et cetera. And then lastly, to identify and react to community influences that affect population health. So the PCMH standards dependent on this competency are 1, 2, and 6.
Thank you. And then our last of the big 5 is team orientation.
And in this case, how this seemed lacking were that healthcare providers really had disparate goals. There were unspoken assumptions, care was not planned, and everyone ended the day frustrated. So ways that this could have been improved is, again, these weekly practice meetings where anyone should feel welcome to bring up problems, to discuss solutions or possible solutions, to review data. This will help every team member build confidence in the team and have more enjoyment working with that team and feel more supported by that team. There should be a commitment to fostering team communication and interdependence, not only at these weekly meetings but at the pre-visit huddles. There should be a prioritization of discussions around the ultimate outcomes of care rather than individual goals, and I spoke to that earlier, where this patient's goal would have been improvement of blood pressure rather than the resident's goal being make a medication change. It's just a different way of looking at your goals for the day. And collaborating with community and public health teams to better integrate population health missions. So this, like leadership, is a competency that is absolutely necessary to achieve any of the PCMH standards, all 6 of them.
One of the things that came up in most of your examples of how to improve has to do with population health. Can you just briefly tell us what you mean by population health? I think that that's something that primary care struggles with, and not just primary care, I think probably across most care settings, that leap from providing individual patient care to what it means in terms of population health.
Sure. So I think one of the things about these resident practices that I alluded to when I described some of the traditional frustrations or limitations are that, at least in the academic centers where I've practiced, we usually take care of the most underserved population of an urban environment. Now, I know there are lots of different types of training environments out there, but that's been my experience. And so the population health of our city, for example, is something that we need to educate our residents on so that they understand the barriers that the patients experience in our community to getting proper health care, making sure our residents understand health literacy barriers, cost of care barriers, transportation barriers, and really certain health outcomes that are very prevalent in a certain population in our city that we function in, such as the basics, uncontrolled blood pressure, uncontrolled diabetes, but then something that might be particularly problematic in a period of time, sickle cell disease, or something that we need to be aware of what's happening in the kind of the broader milieu of the global population health of our cities so that we can better target our efforts to meet the needs of the population we're treating. I don't know if that helps you, but it's sort of just taking yourself away from what patients are on, my patient panel today to what do I need to do as a clinic and as our clinic team to better care for the population that we're caring for.
Thank you. That's very, very helpful. When it's all said and done, what do you think the best or better approaches to interprofessional education might be to effectively foster collaborative practice?
So I'll be summarizing some points that I've already made and adding, just emphasizing a couple others. I really, really feel like the most important step is sort of who you build on your team. And it's building that team with members that truly can build that collective orientation or that team orientation, who want to be a part of a team, who understand what it means to kind of give and receive input from every team member evenly, and who enjoy being a part of that team. So that constantly needs to be reinforced in the culture, that success, again, I'll restate what I said earlier, success is defined as interdependence, not independence. And that is something that just that culture needs to be created. So that can take a few years to build that culture or change a culture. But once you're there, I think that's probably the most important piece to building or to foster collaborative practice. I think that this concept of fluid leadership is really important to really flatten hierarchy again and to make sure that every team member feels empowered to be a leader for the areas that they're the best person in the place to be a leader for. So that's something that I think if we can teach our learners, whether they're medical residents or the other disciplinary learners, if everyone can walk away feeling empowered to be a leader as part of the PCMH team, I think that would really foster future collaborative practice. And for my learners, I really want them to see that nurses in the clinics that I've worked in, nurses really serve as a great presence as a team leader for that piece of continuity for the patients. And so helping residents to work on a team that's led by a nurse is something that we really have seen be successful. The element of shared workspace I want to speak on for a moment. The clinic
that's a really important concept.
Yeah, so this is something that I feel like I've learned to appreciate even more so since coming to the University of Nebraska. In my introduction, it was mentioned that I work in a resident-run primary care patient-centered medical home practice where there are behavioral medicine interns, social work interns, pharmacy students, nursing students. There are a bunch of learners, and we all work in one big workroom in the center of the clinic. And it's just such a wonderful transition to watch. At the beginning of every academic year, when the learners are all new, I often will have a resident come precept a patient with me, and I'll have to help facilitate a lot of the communication or involvement of the other disciplines. But as the weeks go on, just being in the same room and overhearing case discussions, learners become much more comfortable jumping in to offer help when an issue is overheard that they feel they might have something to add or contribute to. And this often happens with our diabetes educator, the behavioral medicine interns, or the pharmacy students. And it's fun to see the medical residents' faces. They often seem in awe that there's someone else who can help them manage this very complex patient. And then as the time goes on, the learners better understand each other's roles and expertise just after day of working together. And then these interactions become innumerable and seamless. So often a patient now, at this time in the academic year, I actually precept this afternoon in that clinic, and a patient will get seen often by social work or pharmacy even before the resident even goes in, prompted by the pre-clinic huddle discussion. And then by the time the resident comes to precept with me, a very comprehensive multidisciplinary plan is already in place. And these residents, now they don't know any different. So it's really fun to see that this is sort of the expected behavior. All the learners in every discipline sees it as an expected behavior, and it's just fostered week after week, day after day, and it gives me a lot of hope for the future for them. The emphasis on these common meetings, the practice-wide meetings, the preclinic huddles, the mini-team debriefings to go over almost M&M style cases like this vignette to say what went wrong, what as a team can we do better, is essential to continuing to grow as a team and foster that collaboration. And then my other hat is my role on the clinical competency committee and my program leadership role, and that is I am charged with providing feedback and evaluation of my residents. So doing this in a very intentional way when it comes to interprofessional practice, using multi-source feedback for all team members to provide formal feedback to each other, and to help use this to map to our ACGME reporting milestones so that I can help provide feedback to the residents about how they are developing in this interprofessional practice series of competencies. So really just so many ways that I think I am continuing to learn how to do better in this regard, and how I think I've changed my practice and my education hat to do so. So that kind of summarizes, I think, some of the most important ways to foster that collaborative practice.
Thank you very much. That was very, very informative. Are there any additional comments you'd like to share? We do have some questions from the audience, but before we get to them, are there any additional things you would like to tell us?
No, I'll just end with saying that, our team of authors, we've reflected numerous times on all the months of work we did in this topic area, that to be successful in our outcome, we actually fell back and looking back, we relied a lot on these 5 competencies for us to be successful just as a group of co-authors and team members. So we laugh at, no matter what team you're on, these competencies ring true and are necessary. So I'll just end on that.
Thank you. Let me address some of the questions that I see from the audience. So can you further describe what a shared model of care means?
Sure. So really that shared mental model, do you mean? Or
Well, that's just what
Okay.
how the question was written. Sorry.
Okay. Well, a shared, let me think. I'll talk briefly. So a shared mental model is to try to help every team member to understand sort of what the team's goals are, and if the team's stated goals are to achieve, X, Y, or Z patient outcomes, to improve what team outcomes and patient flow, clinic-oriented outcomes, to understand what each other's roles are in achieving that, and to understand that those are each other's shared goals. Shared model of care, I'm not sure how I used that exact term previously, but really, I guess that would fall back on that team orientation and that emphasis of the team goals over the individual goals. I don't know if I can answer that question, I guess, any better.
No, that's fine. Let me go through some of these other questions that I've got. Someone wants to know who's included in weekly meetings and how big are the teams?
Sure. So the weekly meetings should include the phone staff, the MAs, the nurses. Really, it includes every team member is invited, social work, but the residents are invited as well. And then typically the clinic manager or the clinic lead, would run the meetings, but that can even vary from week to week. So it's a pretty big meeting, and we are blessed with the space to accommodate that since we have a very big team workroom. But I do think space might limit the number of people at some clinics that could get together for a weekly practice meeting like that. The timing of such can be challenging based on everybody's different schedules, but we have found it to be most helpful to do it over the noon hour between clinics, and sometimes that causes a team member to have to stay out if there's still a patient or two in clinic wrapping up from the morning session. But typically, since it's an every week thing, people can have a presence each week for at least a part of the meeting.
How do you get buy-in from leadership to allow weekly meetings due to access to care limiting time providers have to see patients?
Well, one element is the noon hour. I think we all get pretty used to having to schedule meetings either at 7 a.m., noon, or 5 p.m. So it's trying to utilize some of that time and recognizing that there's going to be some weeks where there's conflicting meetings and you can't make it. But for the most part, at least at the clinics I've worked in, most of the actual clinic staff, the kind of stable people other than the residents who work there, they have that hour more open and free. That's typically when they're eating their lunch, and usually we just have everyone bring their lunches to the meeting to kind of do double work, eat, and get our clinic work done as a team. So for the only people that would really affect as much in terms of the pressure to see more patients and do more teaching, do more, the responsibilities that we're all expected to do as academic providers is really the preceptors. And for us, that's a group of about 12 people that it is a priority to, as part of your role as being an educator in that resident practice, to be a part of the care team. So in terms of the how to get buy-in, that's something that I've been fortunate. Some of the work of my the people who preceded me here at Nebraska had already done a lot of that legwork. So I give a lot of kudos to Dr. Tom Tape and others who have worked for that. Eric Worm was pivotal at the Cincinnati site that I worked at previously to show and to, to make sure that the higher-ups knew that with better patient outcomes and improving access and all the things that I've talked about that could be outcomes of a higher-functioning team, that they'd get their money back, if you will, like to protect this time if it took protection of time, that this could easily be brought back to the health system by better patient care. And I feel really confident in my ability to argue my case for this type of a clinic structure, that I feel like I could go into, higher up meetings and make my case heard and at least fight for that.
One other question we've got, this is similar to Team Steps that is based on Salas's work. Do you use Team Steps?
I don't personally, but I don't want to speak for the experiences of my co-authors who, like I mentioned, have actually a lot more experience than I do. So that's something I can look into. I know several of them are trained and use Team Steps. I personally do not.
Mm-hmm. Who are the members you see as essential to these teams? You've sort of already mentioned it, but I'll just ask it one more time since it was a write-in question.
I'm going to speak, I guess, on two care teams. So the broader care team is pretty much everyone in the clinic is a part of the team. So specifically, I'll narrow down to what I was talking about, sort of the smaller accountable care teams, and who are members of those teams really in the suggestion in the paper, and what I have seen to work best in the two PCMH resident practices I've worked in, is to have one RN, a nurse team leader, who then, with that RN, you might have one or two LPNs or MAs, and then you would have a subsect of the residency, so a number of residents who are all part of that care team. Then the other disciplines kind of cross over all, because there just aren't the same number of learners from behavioral medicine or social work. So basically in that like work milieu, all the other disciplines kind of cross over all the other teams. So the mini care teams are really the nurse and then a panel of residents and then consistent LPN or MA assignment to that team as well. We also have a model that we're doing here at Nebraska where they're actually RN case managers as the lead of the team, and then there is an RN who is our diabetes nurse educator, but then the other team leads are actually the MAs and the LPNs. So there's different structures based on what your clinic has available in terms of team members at that time.
Somebody Twittered, sounds like these tools would be useful in IPE case studies with standardized patients. Any other ideas on how to integrate with IPE?
I like case studies idea. I think that so much of our time is so limited that I really have mainly to this time focused on how can we, through the process of what we do each day, learn from each other and learn around each other. And in that example I used about the transition of how I see all the learners from all the disciplines learning to use each other better in a clinical environment, I see that happen just from being the reinforcement of using each other. But if I needed to do it more formally aside from this, what we suggest in the paper and what I'd like to see happen in my own clinic would be some little mini half-day retreats for the clinic, if it's a Saturday, or if you can actually get the buy-in from the high-ups to protect a half-day from clinic where we shut the clinic down and have a mini retreat with the team. And yeah, we work through some of the case vignettes and we talk about these 5 competencies. We take a step back and realize maybe where we think that we've been embracing these competencies, where team members feel we haven't. So whether it's I actually don't understand the role of X team member, or I don't feel comfortable actually speaking up at these meetings for various reasons. Okay, well, let's take a step back and figure out how we as a team can do better on these competencies. And that would teach it to every team member as well. Yeah.
Do you collaborate with dentistry to address oral health issues?
I wish that we had that set up in the clinics I've worked in. We don't, but I have heard, back when I was at Emory, I do remember in our HIV clinic there was a tight association with the dental clinic, and that was seamless and awesome. So I wish that we had that available here, but that would be something to work towards, definitely.
I think that sort of gets through all of the questions that have been submitted. So I'm going to just say one last round for questions. If people want to throw them out there, that would be great. And then just to give you one last chance to say or address anything that you would like to.
I guess I just am so thankful that you've all asked me to be a part of this today. I've been doing this now and working in a patient-centered medical home training model for about 6 years, and every year I'm just so in awe of what other training sites are doing, and I'm learning more and more every day. So though by no means I pretend to be an expert in this, I do feel like I've learned so much in my years, and I'm so excited to learn more and to improve the training for our residents and to improve the care for our patients.
Thank you so much. This was a wonderful, wonderful discussion.
And thank you to Dr. Leasure and Dr. Lucia for an excellent presentation, and to all of you for joining us today. If you've not already, please visit the National Center website to create a profile, add a resource in the Resource Exchange, or start a conversation with other members. It seems like this topic could provide some rich discussion. A link to the Resource Exchange can be found in the chat box at the right side of your screen. And finally, your feedback is much appreciated. You will be directed to a survey at the conclusion of this session. Please complete the less than 5-minute survey to help us plan for future educational offerings. We'll also follow up via email within 1 week with a link to this recorded session and the evaluation survey. Thank you for participating. This concludes today's program.